video where I take a CR bite. We can either use the lift gauge or the lucid jig, but always I like to use by manual manipulation. So we hold the patient's head.
Hello everyone, thank you for joining us today. My name is Jenny and I'm a part of education team at Medit. Nice to meet you everyone. And as you can see, today we have a new KO here. It's glad to meet you, Dr. Hector.
Hi, nice to meet you. How you doing?
Thank you for being here, Doctor. It's such a pleasure to have you here today.
Thank you very much for joining me, for inviting me to this webinar.
Okay, so for some of you who doesn't know about Dr. Hector, I want to briefly introduce about him.
Thank you.
Okay.
You can move my face everywhere as well.
I can control everything here.
That's good.
Okay, so we became small.
Yeah.
Okay, so he has a diverse educational background, starting with Universidad Europea de Madrid. Is it right to say that?
Yeah, so that's the Universidad Europea de Madrid. That's the Madrid University. That's where I had my degree in dentistry.
Okay.
And then I did an implantology master's in Madrid as well.
Okay.
Yeah. Then in Santo Domingo, that's Dominican Republic, where I had the oral surgery, and then I became specialized in periodontics by the University Complutense of Madrid as well.
Okay, it was a little bit hard to pronounce, so Dr. Hector introduced himself. Thank you.
You're welcome.
We can feel that he's like an all-round player, right?
So I also, well, you're going to see in the presentation, I own my own practice, and we opened the practice after the pandemic. But then I'm also starting some teaching with Dr. Ian Buckle in complete dentistry, where we've been moving around Northern Europe. So we've been to the Scandinavian countries mostly. I'm in Spain at the moment, but really what we're teaching, we're trying to bring it around Europe. And obviously, if this is a very interesting topic, and if we can reach to Korea, that'll be amazing as well.
Yeah, that would be. So you are staying in Spain, but how do you go to Copenhagen?
So it's an hour, only 3 hours flight, and we can move in Europe. Everything is very handy, and we can move around quite easily. And I go every 3 to 4 weeks. So I spend a week there, and then I come back. And the teachings of the modules are 3 to 4 days. They're not very long to be teaching, so it's quite handy to come and go.
It seems handy, but still, it's another.
Yeah,
You're very
it's
passionate.
taking a flight. Oh, of course, it's getting on an airplane, going on an airport.
We expect that with such diverse activities, you will deliver many excellent lectures in webinars.
I hope so. I mean, really, I'm really enjoying this part of the virtual part of this.
Okay.
Even if we are like many kilometers away and it's 10-hour gap difference, we can share knowledge between us. That's really good.
Okay. Back to the topic. So, can you tell us some contents that you're going to discuss about today's lecture, very briefly?
Yeah, very briefly. We're talking about how we're going to produce and deliver splints in the dental practice. I mean, nowadays, you'll see in the webinar that more and more we need to be able to deliver very precise devices as soon as possible. Patients are expected to have things done on the same day or during the same week, where a few years back, you had to take some impressions, you had to have them cast, you needed to have some plaster around. If not, those impressions they can mess up those impressions. And then nowadays, well, thanks to intraoral scanners, thanks to the digital world, we can scan the patient, we can produce, well, we can produce them, we can design them, we can deliver the splint in as little as an hour, sometimes an
Mm.
hour to 2 hours. So patient can they can have a coffee, they can sit down, they can relax. So we
Yeah.
could have some sort of splint or night guard, something delivered on the same day. I
Mm.
mean, Medit is helping a lot with this because
Oh.
we can use those NTI splints, where are the very tiny bits in the front that
Mm.
take only 20 minutes to print, and you'll see how um, printing it's really good nowadays, and it's getting better and better.
Mm.
Milling, we can also mill them, but then sometimes we know that milling can take big equipments, expensive equipments, and sometimes they can take even longer than printing.
Oh.
So we're gonna try and summarize everything, see if you can get something out of this. You can print your own splint in the practice, at least give it a go. Um, After watching this webinar, if you find it very interesting, there might be some steps that they might be difficult to overcome,
Mm.
but I'm here to help. Anything you can ask
Mm.
me, and I'll give you my contact at the very end as well.
Mm. Thank you. Everybody will be so interested about today's topic.
Thank you.
Yeah. So if you're ready, let's get started.
Thank you.
Good day, everyone, and thank you for joining me in today's webinar. My name is Hector Fernandez Baca, and I am thrilled to have the opportunity to share my way of doing things with you in this presentation. Today, I'll be talking about splint. I am sure you all recognize a traditional splint in this image, but lately to me, a splint looks more like this. As you can imagine, I'll be talking about full coverage splints. More and more, I see patients coming to the practice with a night guard. Sometimes they have it just to keep their teeth from grinding, just to have the teeth apart. Unfortunately, most of them have a poor design or a fit. I see them, they don't even bite on one side, or they have only a contact in the back. Also, we all know that those splints are costly to be made. I mean, they need to be sent to the lab. There's a certain delay to deliver. Sometimes if we send them some impressions, they might even take a full week to have a splint done. And sometimes the fit is not as good as we expect, which that can lead to more appointments with the patient. And it's just a bit of a disappointment to have something that we've taken some impressions in the best possible way, and we end up having to send the patient back home. And even if we end up adjusting the splint, we might take a long time to adjust it to have it perfect or where we want it. So I believe that using technology and the Medit app applications, I've been able to overcome all those issues. Today, I would like to share with you how I how I produce and I deliver the splints in the practice in an efficient, predictive, and cost-effective way. So the way I do it is first with an STL file of the patient's teeth in a certain bite. We're going to be seeing which bite to take and which vertical dimension we're going to be using. Then we're going to need a design app to be able to design the splint. And then we're going to be printing our splints with a 3D printer. I got a few here. This is a small lab that I got inside. This design can be done in around 10 minutes, and then printing and processing can be done in around 1 hour to an hour and 30 minutes. And then delivery can be done in around half an hour, but you can deliver that splint on the same day if you liked. This whole process and this full protocol that I'm going to be showing you makes my whole life easier. Then the practice runs more efficiently, and the fit of the splint has never been better. I can see how um, I do minor changes that I see on a patient that I try to fit a splint and it doesn't really mm, go too well. I can do some adjustments. I can reprint on the same patient with those adjustments. I don't really need to be trimming too much. I just see which which part of the splint I need to alter, and I just change it. So all those little things um, help me into my daily practice. So I can tell you this because I do this in an everyday basis. I have many splints fitted throughout the week, and I'll be showing you with small videos how we're going to be able to do this. But before we get into that, let me introduce myself. This is me. I'm a general dentist based in Malaga, a city in southern Spain, where I've been practicing for the last few years now. About my professional journey, I spent 6 years in the UK right before I finished my degree, where I've been working in different private dental practices. During that time, I really improved my skills, especially in the area of occlusion. I think because I have my own occlusion problems, I kind of got really interested into getting to know exactly what does TMD mean and what does occlusion mean. I had the opportunity to study at the Dawson Academy, and I also had a really nice chance to work alongside Dr. Ian Buckle, and he's been a huge influence on my approach. I know he's still actively teaching about the principle of complete dentistry. And then, as where for a work, I am currently leading a family dental practice. I've been working alongside my father and my brother in this project for a while now. We call it Generación, which means generation. We call it dental clinic, as we are the fifth generations of dentists. And I kind of feel that I did not have a choice because, again, my father was also a dentist, my grandfather was also a dentist, so my whole family were dentists. But the general idea that we come to a conclusion and we have a practice where we eliminate the stress of coming to the dentist and we try to make it as appealing as possible. I think if you own a dental practice, you can agree that it does allow you to apply all the knowledge and techniques that you acquire over the years. So I'll be showing the process that I use, and you'll be able to apply everything that I'm telling you today in as soon as the next working day. Apart from dentistry, I really enjoy cooking, and I also know that a recipe can easily be followed if you got the right ingredients. So today, what we're going to be needing is a dentist, which in most of the cases is going to be today's attendee of any of you. Your role will be to make sure that the process is followed and all the finishing details. Then we're going to have the reception as part of the first consultation of follow-up appointments, which are very important and we're going to see in this presentation as well. Nurses to be able to take some records, and they are also needed to produce the splint or design the splint, and then the lab to be able to finish it off or manufacture it. But again, not everybody has a big team, and I'm sure it can be frustrating to say, well, I don't have anyone to help me. But most of the cases, the same dentist can do the 4 steps because it's not going to take a very long time to learn. The learning curve is not as difficult as we can imagine. So the dentist can do all 4 kind of parts of the splint. Knowing that, the equipment needed will be, I mean, we're gonna need 4 things. Not everybody will have all those things, but it's gonna be very helpful for the workflow to have all those things. Ideally, an intraoral scanner. If not, we can send the conventional impressions to the lab, and they can send us the STLs files. I use the wired Medit i700. A splint design app, I like to use the Medisplint app. I've been using other apps, but I think this one is probably the simplest compared to the others. Then a 3D printer and a curing light machine. The post-processing is a must. We cannot use the printing materials that we want without it. As an alternative, we could also have a milling machine. We're going to see the pros and cons about it. But then I use several printers. You see them, 3 of them are the same, 2 of them in the back are different. Creality is a good one. Any cubic, frozen. I mean, all of them do the job. But I'll show you the one that you can get from the next full working day if you like. And then as an optional, the polishing kit to deliver the splint as nice as possible. As you can see, printers nowadays can be quite inexpensive, as well as the washing and curing machine. So this is just the Creality Store website. I think you can find many on Amazon, but this one is 329 euros, and then the washing and curing is 149. For less than 500 euros, you can have a decent um, set for you to print your splints, but also if you're gonna think about printing your own splint, you can also start using different resins. You can print your own provisionals, you can print models, you can print your own surgical guides. Once you get into the world of printing, really the limit is going to be things that need to be milled. The rest, if we can print it, we probably will be able to do it in the practice. Once we got everything that we need, we got our ingredients, we got our team very motivated and ready to go, we need to understand where we're placing the splint. There are several types of splint, and the indications are going to vary from case to case and from patient to patient. Those full coverage splints, they're going to help us from diagnosing TMD problems. They're going to help us to check TMJ stability. They're going to help with relaxing the muscles. They can prevent teeth grinding, especially at nighttime. And then they're going to protect any dental work that we're going to be placing. For today's presentation, we're going to focus only on those last two indications. I think it's too broad of a topic if we try and focus into when and how using the splint to check the TMJ or to diagnose the TMD. But I think we can all agree that preventive teeth grinding and protecting dental work is two simple things that we can do at least to help our patients. So, in today's presentation, I'll guide you through the entire process from patient consultation to record taking, splint design, manufacture, delivery, and follow-up of our splint. Our goal is to equip you with the knowledge and the skills to deliver occlusive splint efficiently, effectively, and with minimal expense. I need you to give you the ability to implement those techniques into your practice. I need you to do it as soon as possible. Probably, if you follow these steps, you can have it done by the next working day. So thank you for being here. I hope you find this presentation informative and useful. First of all is the patient consultation. This is the initial step that we need to take in order to start our process. In our practice, we employ a thorough approach to gather data. First, I like to engage with our patient with a discussion. I like to listen first before I ask any questions, and then I'm going to be looking for some clues in their history and symptoms and the concerns they might have to decide which kind of splint they're going to be using. This steps is fundamental because we don't want to be placing a splint in a patient that already has jaw problems if we don't really know what we're doing. So ideally, we need to understand the challenges and the needs that we're going to have. Then after we got all our data, I like to take an x-ray. I start with a panoramic x-ray just to make sure I have an overall view. Sometimes we take CT scans as well. I like to check if the joints are okay or not. But really, we want as an initial step to have as much information as possible. Also, for a legal point of view, it's nice to have, well, when the patient came in the first time, this is how he was. Then we're going to take some photographs. I like to use a reflex camera. I got a Canon. I got a ring flash. I got a macro lens this is going to help me to have structured photographs, and I do them in every single patient. Once they come in, I have extraoral and intraoral pictures, and they're going to aid me in my assessment. They're going to help me with the documentation, and I'll be able to explain all those things to the patient through the images. Then I like to take an intraoral scanner. It's normally not me, it's normally the assistant. My assistant that takes a upper and lower scans, and then a bite in maximum intercrustation in MI bite. We use the Medit i700 as an intraoral scanner. Nowadays, I just don't feel that we should be using, obviously, we need a scanner, but we should try and eliminate the need of traditional impressions just because patients, I mean, we all know they can be quite uncomfortable. So if we can, let's try and avoid. As part of the record taking, we will need an upper and lower digital impression at a specific vertical dimension. This can be achieved thanks to a lift gauge or a lucid jig. We do this because of the difference between MI and CR. We're going to see how that opening in the virtual articulator can affect the fit of the splint, especially not in the fit on the jaw that we're going to be placing it, but the way it bites against the opposite jaw. We're taking the upper scanner first. If you have a scanner, you all know how this works. But if you don't, you can see this is not going to take very long. Sorry about the frame per second. I think I just don't understand how this works too much with PowerPoint. I think it just froze a bit. But then it's going to take around 2 to 3 minutes. It doesn't take longer, especially if you know how this works and if you follow the manufacturer's protocols. I use Medit, so I just follow their guidelines, and it works really, really well with me. Then we're going to take a bite right after finishing off the lowest. The first bite that I like to take is the MI bite. So we just ask the patient to bite together. Once the patient is biting together, we scan the right side, we scan the left side, and we have a bite. But then this is the important part here. I like to add another bite. So on the lower left corner, we can add another bite, and then we're going to be placing the lucid jig or the lift gauge to take this bite. I'll show you how to do it. This is a video where I take a CR bite. We can either use the lift gauge or the lucid jig, but always I like to use bimanual manipulation. So we hold the patient's head, we stabilize the head, we do the bimanual manipulation, and then we scan the patient. In this video, I rather hold the patient's jaw and then ask my assistant to help me scan both bites. Then this is just a lucid jig. We're just going to be using some bite registration material. We're going to hold that in place, and then we're going to have a flat surface where the patient is going to be able to bite. So we just use that bimanual manipulation again. We just need to make sure that we have at least 2 millimeters in the back. Once we have it, we can scan one side and then we scan the other side. So thanks to this, we're able to have a bite, and you can see that there is a big difference between having just an MI bite and having a CR bite. So in the Medit app, having it the bite right does help a lot, because in this case, the program has opened the byte on its own, and then it's just slightly guessing where the byte is going to be. That's just going to add a few errors. And then once we try to fit that splint, that's not going to be great. So what I tend to use, and then you can see the difference here, the byte opening is at 0 here. So once the byte opening is at 0, we're not altering that byte at all. You can change it, but ideally I don't like to change it. I've taken the correct byte at the vertical dimension that I like. So the main difference is this distance compared to the other one. That probably was shorter because the patient was sliding forward. Once once we got all the records, we either ask the patient to go for a walk or we give them an appointment for the next day. The splint production phase starts with the design. That's the very first thing. Then we're going to manufacture the splint. We're going to be polishing the splint, and I'll show you how to deliver and adjust the splint accordingly. In the splint production phase, I use the Medit scanner, and then thanks to having the Medit scanner, have the Medit splint app on the same computer as I'm taking the records. So at the moment that I finished, once I finished, I can start just asking my assistant, can you start the design for me? While she's doing the design, or you can be doing the design, I'm talking to the patient on how we're going to do this. So a good thing about digital is they're able to see their mouth, and they're able to see exactly what's happening and what are we doing and why are we doing those things on them. Also, it's going to save us some time because we don't need to send anything. We don't need to write a lab prescription and know exactly we want an upper or a lower, or we want the right kind to be off the guidance or whatever it needs to be done. We don't need to do any lab prescription because we can just start doing it, or our assistant can start doing it. And then once she's done it, or most of it, we can just do all the finishing bit at the very end. But it is really important that we have that vertical dimension in the right position. We need to maintain that vertical through the entire process, so we have a splint that's going to be fitting in as good as we can. You'll have the opportunity to see an example of a case that I designed in the MediSplint app. This is the one that we taken the records before. You can see this patient has an open bite, thanks to having used a Lucy jig in the right vertical dimension. Then we're just going to go ahead and click on Michigan on the upper, and then we're going to do it manually. Nowadays, AI is taking over many parts in our life. Here, AI helps us to get the splint. Let me just stop the video here. To get the splint in less than a minute. I mean, we just click AI and then we have it done. Nevertheless, I still follow the process just to make sure I produce exactly what I was expecting. Both work fine, it's just a matter of preferences. Here you can see the byte is set as 0, so we're not going to open or close that byte. Then we're going to be following the inner surface. That can be changed. I like to have 80 microns between the splint because of the material that I'll be using. I'll show you the material that I use. Just because I don't want that material to be too close to the tooth or too far apart. Then we can have smoother or rougher surface, especially if we have very retentive or less retentive teeth. This is what's going to grip, the splint is going to grip to those teeth. But if we have very non-retentive teeth, I'd rather have more retention. If we have very crowded teeth, we don't want any retention, and sometimes we need to block those teeth off. So you can see, you can change here that retention, that smoother surface, and then we're going to design the outer line. I like to have it just above the equator of the tooth for full coverage splint. You can change everything in one go with buccal side or lingual side. Again, I like to go manually to have it exactly what I want. And then once we have this to me is not the perfect splint because we don't have any guidances. So I like to go into the manual mode and then on the design mode, and then I like to add those guides. So we're just going to be adding to the front. I mean, we could have some videos of the patient movement, and I think you can add them in this app as well. But I just don't find them very useful because the guides that I want to create, I want them in a specific way. So it's not just the guide that the patient have, but the guides that I want to introduce. So this is just the finishing splint, and then we need to just export this to be able to print it. Once we have a splint in an STL file, we can either print it or mail it. I mean, depending on which one is it, and depending on the material that we're going to be using, the parameters that are introduced, they need to be changed. Obviously, for my parameters are not going to be the same as the ones that you're going to have. But the main issue with milling is obviously it requires a very expensive machine. 3D printers are very affordable and they're accessible. There are many people that have a 3D printer at home. They're also smaller. You can see I can have 4 or 5 of them with different resins here. And you just need a cupboard or somewhere to just place them. You just need to plug them somewhere and they're ready to go. They just need a flat surface, ready to go. The advantages that we have, obviously, we can do them we can do the splints in house. It's going to eliminate the need of external labs, and then it's going to save us some time. And it's going to reduce the production cost. Materials cost wise, I mean, you've seen how much a printer costs, but material wise, we're going to spend 4 to 5 years to make one of those splints in terms of materials. It also allows us to quicker turnaround times because obviously in the same day we can deliver the splint that we designed. We're taking the records from that patient, but it also is going to help us in ways of as a teaching exercise because once we design our own splints, we're going to see where the mistakes are and we're able to correct all those mistakes. If we have a lab technician that's going to be doing the splints and we're not sure how much we had to trim, we can kind of tell them, yes, I had to trim the guides or there was an open bite in the back teeth. If you design your own splint, you're able to correct all those mistakes and have a better fit on the following patient. So onto the material that I use, this is the one that I use the most, Crisply Soft. The brand is Key Print. I've used the Key Splint Hard as well. I found the soft is a bit easier to use because it's just going to allow me to have that little of a module of elasticity that's going to allow me to click that splint into the patient's mouth. So both of them work just fine. I've tried others as well, but this is the one that I'm using nowadays. Then we have a small video just of the printers that I have. This is what it takes to just print. Just click the parameters. We load the STL file. That's how long it's going to take. This is just a quick video and to see obviously how that goes up and down. And then once it's done, you have the splint there. Then we have to take it out of the tray. And then once it's out of the tray, we need to clean it. So the way to, well, I like to first take all those supports out. And then once the supports are out, we clean it with isopropylic alcohol. We can either have a bath in ultrasonic bath. I like to use a toothbrush that helps me. Is more than enough. And then the post-processing, that's the more important part of this kind of splints and material that we're using. And the layers that I tend to set, they are in 50 to 100 microns. Less than that, I mean, I know printers can go up to 30 to 35 microns per layer. I don't think that's necessary, especially in a splint. Maybe we want to do some temporaries, we want to have the best precision, but then for a full coverage splint, I don't think you need more than 35, less than 50 to maybe even less than 100 microns. With 100 micron, I think it should be perfect. And then the more microns, I mean, the less microns you have, the longer it takes. If we want the splint to be done in an hour, we can't print it in 35 microns because it's probably going to take 3 hours. Then into the splint polishing, where what I use is the same brand, is out of Keyprint, is K Polish. They have their own protocol. It's just a 6-step kind of protocol. You have the brush, the burrs, the brush, and then with some polishing paste, you can have a very, very nice result. It just makes my life easier, and then the um, the final product that I'm giving to the patient looks so much nicer. Then into the splint delivery. The day on the delivery, we are going to be using a flat burr. I'm holding at the moment different kind of burrs. I think anyone can have those kind of burrs in their practice. Ideally, we're aiming to have something quite flat. I don't want to be poking and placing any holes into that splint. I want to be adjusting that splint quite flat. The first thing that I do is just removing a bit of the excess because all those supports were there. So just making it a bit flatter. So to get the marks that we're going to be having, we're going to use articulating pepper. I always use by manual manipulation. And then we ask our assistant to hold the paper in place. Once the paper is in place, we have a few marks. We just trim those marks. Again, always be thoughtful about having it as flat as possible. And then once we're all done, you should probably have something like this. When you have all dots and then marks in the front. That I've been marking this so for as a teaching exercise, just to show how it should look like. Ideally, I like to use 60 microns paper. I don't think you need to use anything thinner than that because sometimes it doesn't really get the marks in. You can also use a thicker one, but if you are finishing off, I think you probably should get a 60 micron paper. 200 micron works if we're starting to do the first few marks, but then after that, please go to a thinner paper. If not, you're going to get marks everywhere and you really don't know where to trim. Then if you are unsure or you want to have go into the next level, in addition to traditional articulating paper, we can use electronic tools like Occlusense or TICScan. Both they give you real-time data on occlusal forces, the pressure points, and it's going to show you where the guidance are. At the end of the first appointment, we should get something like this. It doesn't necessarily need to be perfect, especially in the first appointment, because the patient might have some muscle tension, might have a bite that's a bit all over the place. But then the more we get to that point, the better, ideally. And then we're going to be seeing how those adjusters we're going to be doing, how we're going to be doing those adjustments now, how once the patient goes home after the delivery appointment, we're going to ask them to come back in a specific time frame. Ideally, we're going to start to see some changes in a week time. I just don't feel like they need to come in the following day, but a week is enough time for them to start getting used to it, wearing them. We need to ask them, have you been able to wear it? Have you been able to, are you comfortable when you wake up? Do you feel any tension or tenderness in your muscles? It is really important to just not leave them with the splint. I've heard some dentists that just give them the splint, off you go, you're free to go. Just don't clench your teeth or don't grind your teeth or whatever. Just have a piece of plastic between your teeth. That's not the idea. We need to make sure that we monitor all the changes that the patient have and we always have the same bite. I even heard I mean, I don't know in other countries, but in Spain, I even heard some patients that they had those splint being posted. We can't post a splint, definitely not. We need to make sure that the bite is correct, and we need to make sure that all the changes they're gonna last. Then we ask the patient to come back in 4 weeks time. Again, if at a week time the patient comes back and the splint is a bit unadjusted, we just same principles, trim the with the flat burr where the dots are, and then we have an even bite everywhere. At the 4th week, we normally have a better understanding of what's going on. Most of the time, we have some muscle relaxation. We might have even some de-inflammation in the joints. But ideally, what we want to have is to have a stable bite. So the bite that doesn't change. If the bite stays in the same position, then we can be happy that we're doing a good job and then we're in the right track. Again, 12 weeks time is only just to give us enough time to see a long-term stability. If we have a 12 weeks time, no changes at all, we can rest at home and make sure that the splint is being fitted properly and is doing well for the patient. Obviously, he can tell us, okay, this is good, or feeling any pain, or I do have some muscle issues or some headaches. All those things can be addressed throughout those 12 weeks. But if after 12 weeks the patient is comfortable and has been able to wear it every single night, you should be relaxed at home that the splint is probably fine. Then this treatment part here is just because splints can be done before treatment or after treatment. You could have some treatment done on the patient after those 12 weeks. But then the most important part is the yearly review. I ask the patient to come once a year, either for a clean or for a checkup. In those clean or checkups, I just make sure, and I always ask them to bring their splint if they had one done, either by me or by anyone else, because again, I see those splints that they're not very well adjusted, and I want them to bring it just to see what they're wearing. Right, finishing off with this presentation. Producing and delivering splint is a journey, and I have encountered many problems throughout mine. I'll be very surprised if you don't find any issues during the whole process. Hopefully, you can apply all this knowledge and you can start printing on Monday or the next working day. But the most common challenges that I had were, first of all, printing. There are things that can go wrong with printing. Parameters cannot be introduced right. If the lid is not placed properly, sometimes you can get the materials to be set, and then can't really get the printing properly. You can have too little or too much resin in the tank. There are things that can go wrong, but I think we can address those things. This is just practice. The first print is not going to be the nicest. You can either, sometimes, I mean, the first time I had a printing, I asked the lab to do a splint for me, but I also printed one. Once I had both, I tried them both. The patient left the practice with the splint that the lab made for me. But then I tried mine, and then it wasn't great. It wasn't the best, but it probably could have worked, especially when those splints are for the short term. If we want those splints to be in a long term, for a few years time, we're probably the first printing that we're gonna do is not gonna be amazing. Then don't expect to just click print and then have everything done. Those printers, they are not as expensive as other printers, because you need to set all the parameters manually, and you can get really nice printers for hundreds or thousands of euros or dollars. Um, but then they have all the parameters for you. You just need to click play, and then you can be home with your phone, and then you click print, and then it prints everything. Here, you probably need to be around it, making sure that things are okay. every now and then set all those parameters, and then just making sure that obviously it works. Then a second problem that I've encountered is the proper split fit. Um, I've been able to overcome this with the Medit app parameters. I think you can either have very crowded or very non-retentive teeth, but then removing or adding retention just give me a really, really good splint. And then also the material that we're using, you have a very thick or a very hard material. It's probably gonna break before it goes in. So I'd rather have some sort of material that has a bit of elasticity, just so it goes in quite nicely. Then the bite adjustment. I mean, you've seen the video how, I mean, you can have that bite adjustment with a flat burr, but it can be tricky because sometimes you just trim everything, you end up removing the dot that you should be removing. I like to do it out of the mouth. I like to do it not in front of the patient, but I have like a small cabinet where I can do it. I find it easier to do outside of the mouth. I know some people have it in the mouth. I just don't find it very easy to do. I just ask the patient to take it out, I trim it, place it back in, and do that a few times. Then patient compliance is key to this. I mean, we can be the best at delivering splint, but if the patient does not wear the splint, that can be very, very, very frustrating. Sometimes we expect some changes in the bite, and then we end up seeing the same dots or the same that we don't expect those. The appointments that we give the patient are a week apart, but then the patient just says, "Well, the first week I haven't been able to wear it, or I have it 5 minutes and then I wake up and I have it in my hand, or I don't find it in my mouth." mm, we can think we're doing something wrong, but sometimes it's just the patient. In reality, they're just not wearing it, and they're not very good at it, at least at first. There's not one single patient that is very comfortable with the splint on the first day. They know it's going to be good for them, but sometimes it's not easier to convince them that it's going to help them really. And then lastly, the changes that we're going to see, they might not be in front of us. I mean, pain is very relative. Comfort sometimes is due to the patient's stress in life. They might feel the splint comfortable one day, but then they're going to hate it the following day. All those changes, we need to write them down, monitor them, and then make sure that the splint is correctly adjusted. Electronic tools like the ones that we mentioned before can really help with this, because if we have an electronic paper that give us the exact force in each dot, we are sure that we're in the right spot. And finally, in conclusion, occlusive splints are a very versatile tool that are going to help us with bruxes and to protect any of our dental work. A detailed patient consultation, including history, imaging, digital impression, is the foundation of the effective splint therapy. We cannot have a really good splint if we don't have good records. Then a 3D printer offers a precision. It offers also cost effectiveness. It's making our splints in house that it is very viable. It's a solution for us to have splints delivered on the same day with the expertise that we're going to be gaining through the design, but also on the way that we're going to be seeing our own deliveries of our own production, and we're going to see where the mistakes are. The adjustments are going to be very little, and the bite assessments is going to be key to see and to check all the changes on the patient's mouth. And then we're going to need a structured follow-up schedule to monitor the changes and the comfort of the patient. As for my recommendations, I will encourage you to continue your education in occlusion splints, and if you have time, give it a go. I mean, just give it a go, because it's just buying a printer, and then start with simple things, maybe an NTI splint, maybe something quite simple, just for you to kind of have a feeling of how the material works. Also considering investing in intraoral scanners, 3D printer technology, and electronic articulating papers. I mean, there are many benefits of moving into the digital world. I would recommend to educate the patient as well about the benefits of occlusal splint and the importance of the compliance. And then collaborate with dental laboratories if you can't really get into the digital work for production if needed. You can do your own design and then just ask them to produce it. Uh, and also involve your dental team, not only in the design but also in the adjustment process. I mean, it doesn't necessarily need to be you, the person that's doing everything. To monitor the changes, you can have the assistant to take pictures or to see if the bite is correctly aligned or not. And then finally, maintain a detailed records for each patient to track the process and all the adjustments. So I hope that this presentation has given you insight onto the occlusal splint. By implementing these techniques and recommendations, you can enhance your patient's care and make occlusion splint, I think, an integral part on your dental practice. It's definitely not easy to kind of get some free time to do this, but I assure you, if you do have the time, it's worth your time. Remember that our commitment is excellence in dentistry, and this is just going to elevate our practice into the next step. So thank you all for being here today. I would also like to thank the organizer for making this possible. And if you have any further questions or if anyone would like to know about a bit more about this topic, please don't hesitate to reach out. You can contact me via email or connect me on social media. That's the links of Instagram or my Gmail. I always like to listen different points of view on the subject. It's a very broad topic. I've narrowed it down to two kind of indications. I tried to condensate this in a 45 minutes presentation, but I hope you got something from it and then you can put it into practice. Once again, thank you very much for your attention. I think we're going to have some time for Q&As as well. Thank you very much.
Okay, thank you for sharing all your tips with us, Dr. Hector. So let's
Thank
move
you.
on to Q&A sessions.
Thank you very much.
Okay. So today we've got 5 questions in total. 6 questions.
6 questions. Yeah, that's good.
It's a lot, but let's start with the first question. Okay, question number 1. Is it easy to use the Medit Splints app? I know other companies also have Splint apps, but what are the advantages or distinctive features of Medit Splints app?
Oh, that's a really good question, because nowadays we have lots of companies, lots of softwares out there. I've used many, Jenny, if I'm honest. I've used a few of them.
Yeah.
What I can say about Medit is the first thing I could say is simplicity. It's very simple to use, very user-friendly. It gives you the opportunity. You don't need to be really good with computers. You don't need to be a really good technician in dentistry to be able to use this software. So I think anyone could use them. Even dentists, nurses, receptionists can use them, because at the end of the day, it's a really easy workflow. That's a good advantage. Another advantage with this, and I think AI is taking over in our life. There's going to be big congress about AI really soon, and if there are any, there should be anytime soon. It's 2024, and AI, the feature that Medit has with the AI, it's quite advanced compared to others. With one click, you can have nearly the whole splint done. So that's a big advantage as well. And then I could also say that it's an open software. And if you have any other scanners, you can use Medit as well. That's why it's really good. I think it does help a lot. You don't have many limitations with it.
Is there any special or specific function that you like the most in the Splint app?
So there is one, and as I say, it's the AI function. AI. So when you click on a button, straight away you can have the splint done. It's literally 10-15 seconds what it takes.
Yeah.
where most of the companies, you need to go through all the steps.
Yeah.
And the more the AI is advanced, the more it learns with it. We're going to have our own kind of likes of splints really, really, really soon.
Okay, thank you. Okay, let's move on to the question number 2. What is the most effective way of diagnosing TMD?
That's a quite broad question.
Yeah.
When it comes to TMD, and we haven't spoke much about it in the webinar, when it comes to TMD, is another full topic concerning how to diagnose TMD. The first thing that I'll ask the patient, the first thing that I'll try to do is ask the patient for symptoms, for signs, anything that the patient might feel. That's going to give me some pieces of information. Then imaging is really important. We need to either take some x-rays, we can take some MRIs as well, but sometimes it's not that easy to find somewhere to take an MRI.
Yeah.
So the last thing that we can do, and I can show you how to do it, is with a load test. So we need to load the joint. We need to see if there is any pain coming from it with some pressure when we apply some pressure. So it's a combination of things. It's never just one thing is going to give you exactly the diagnosis. But then thanks to one of those features, you'll be able to find if the patient has TMD or not.
Okay, it means it's a combination of all the symptoms.
Yeah.
Okay, question number 3. Has there been any case where it took a very long time to relieve TMD or where TMD couldn't be relieved?
So sometimes, again, it's a big topic. But yes, there is patients. I have patients where in a few hours, a few days, the patient can be symptom free because that TMD can come either from muscles, but also it can come from 10 other places. I mean, 10 other different places. It's not only the pain coming from the joint, but sometimes it's also the differential diagnosis of TMD can be a nerve, can be something what we call more a psychological kind of pattern. It's not only there is a pain in the joint or in the muscles, it can be a combination of things. And I had patients where it took me either from a few hours to a few days to up to 6 months. And also there are cases where I can't really help the patient. So in dentistry, we can help some of the patients, but not all of them. Some of those problems may come from somewhere else. They might come from the neck. They might come from the brain. If they come from the mouth, we can help them, definitely. But if it doesn't, then we're very limited.
I see. Okay. Question number 4. Is TMD more related to masticator muscles or is it primarily caused by occlusion?
The patient is different on the patient. Some patients trigger very easily. Some patients, they don't trigger. So we have the ability to adapt as human beings, to adapt really well. Some patients, once you kind of have them on a splint, they improve massively, very easily. Where others, they can take quite a long time. And some others, they might not be able to improve at all. So it's not only an occlusal part of it, it's a combination of things, as I said. So the patient, if it's occlusal, they're going to improve very easily. But if it's not occlusal or not muscular or not related to the joint itself, which is the bit up here, then we won't be able to see any improvements.
I see. Then in that case, splints helps.
Splint, they can help, but they definitely won't solve the problem. So I do have patients sometimes that they might be in a 9 out of 10 in pain. So you ask them, are you in a lot of pain? They are in a lot of pain. And they can come to a 7 to a 6. But when it comes to those very difficult patients, as I said, it's more like a psychosocial part of this. It's not only treating the disease itself, but also everything that's behind. So the patient might be on some other problems in their lives as well.
I see. Okay. Question number 5. Do you think is airway essential when designing splints?
That's a really good question, and I think it's really important. I could say it's essential, definitely, because when we place some sort of splint, we're going to relax some muscles. If we have any airway pressure here, so our muscles, if we do have any airway pressure, again, that's another topic that we can talk about. All the muscles are in our neck, they're going to relax and they can compress the rest of the neck. So if we're trying to sleep, we can have some sort of sleeping apnea where we stop breathing, where we can't really take enough air. So if we don't take enough air, we can stop breathing. We can have so many other problems that come with not being able to oxygenate our brain or the rest of our body as well. But definitely, if we place some sort of splint and we relax the patient's muscle, we need to really monitor the patient's symptoms, and we need to see, is the patient okay with the splint? The thing is, in Spain, what I tend to see very often is we give the patient a splint, and then off you go. You can go home with the splint. I'll see you next year. So we can't really do that, because if we do relax the patient and the airway can affect, he can have some sort of sleeping apnea, we need to monitor, we need to check that the patient is doing okay. Also, there are some devices where they're going to advance the jaw. So splints can help as well with breathing problems if we do advance the jaw. But the splint that I was talking about, and is only one kind of splint that we talked in the webinar, is the full coverage splint. Those kind of splints, they're going to relax the muscle, but also the joints and everything around it. So the jaw is going to go back. If the jaw goes back, then we can have problem with the airway. So really careful with it.
Okay. So last question. Question number 6. Can you explain the workflow of deprogramming and reprogramming?
Yeah, it's a big workflow, and to see how to reprogram or program a patient, deprogram or reprogram, we need to see everything as a whole. So it is true the splints, they can deprogram the patient, they can set him in a position where they're not used to be, because the patient is used to be in one position only. So the patient is only positioned with the jaw in a position where the teeth touches each other. So if we remove that factor and teeth are not touching each other anymore, but we have a piece of plastic in between, then the patient is going to be deprogrammed. Then if we remove that piece of plastic, the patient is going to reprogram itself. But what we are trying as dentists to do is to reprogram them in a position where we feel confident enough, when we feel comfortable as well. Say we're going to place some restorations, say we're going to do some orthodontics. With all of those things considered, then we need to see, where do we want the patient to bite? And at the end of the day, what we're trying to have is some sort of reference point. Once we have that reference point, then we can work around that.
So how long does it take when doing deprogramming and reprogramming? Which one is faster, or how long, real months, it takes?
So deprogramming can, some patients is different. It differs on the patient. So if the patient is really easy to deprogram, in 5 minutes the patient can be deprogrammed.
5
Then
minutes?
the reprogramming normally takes a bit longer, because you can ask the patients to be kind of relaxed quite easily. Some patients, they do take longer. But if they deprogram themselves really quickly, once you tell them, okay, just go back where you were, they kind of don't really know where they were. So they need to allow the body to reprogram itself. And it normally takes them at least 24 hours. In 24 hours, they kind of reprogram themselves to be in the position where they used to be. I do see patients as well. They wear the splint at nighttime. They wake up, they are deprogrammed, and then when they gonna go and have breakfast, they are already pre-programmed again. So some patients, it depends on the patient. Some people take longer, some patients take less time.
Okay. So
But it's a
thank
really good topic and it's really wide, and we can talk about
Yeah.
an hour about it if we wanted to.
Yeah, so it would be really great if you can deal with this topic later on with the next webinar.
No problem. We'll
Mm.
definitely do it.
Okay, so it was all about it for today.
Thank you very much, Jenny. Thank you for all the present people watching the webinar.
We were so happy to have you here today. So, okay, so we'll see you next time.
Thank you very much, Jenny.
Okay, so you'll be able to watch this webinar on our YouTube channel and Medit Academy once it's completed. Thank you for being here, Dr. Hector.
Thank you. Bye.
Bye bye.